Sir, we are live now.
Perfect.
You can start with the session.
Okay. So good afternoon, ladies and gentlemen. Today we are going to talk about psychological needs in people living with diabetes. So basically what we need to understand is people living with diabetes do have certain difficulties in terms of their psychological needs. So diabetes is just not a disease of physical health. Actually, when a diagnosis of diabetes comes in, it comes with a huge impact on emotional health too. We all know diabetes is a relentless disease which requires constant attention, awareness, and it affects decision making in day-to-day life. And that's why people who live with diabetes are twice as likely to suffer from depression as those who do not have. And the depression stays for longer duration, and the frequency of depression is more in people living with diabetes compared to those without diabetes. There are other psychological conditions also other than depression which are seen to be associated with diabetes, and we will try to discuss about them. They include diabetes distress, fear of injection or insulin, then fear of hypoglycemias, and many times people with diabetes have eating disorders. We all know that most of us are obsessed for eating, and when a diagnosis of diabetes comes in, it has got a lot of impact. Then poor emotional and psychological well-being is associated with poorer quality of life, and that is what it happens in people living with diabetes. That leads to poorer management of diabetes, and ultimately it leads to increase in the healthcare cost. So this is how psychological needs of diabetes can be understood. This is how psychological needs in diabetes affect. Now, let us understand why these psychological needs do occur in people with diabetes, or why do they get psychologically involved, depressed, distressed. Basically, diabetes needs self-management, and self-management needs blood sugar monitoring, dietary control, then adequate medication, insulin, regular physical activity. So somewhere or the other, the freedom of life which was there before getting diagnosis of diabetes is lost. And that is what we call diabetes self-management is demanding and complex. And thus it leads to a lot of psychological stress. Let me remind you, diabetes is not merely a physical health condition. It has behavioral, psychological, and social impact. You know, when a person gets diagnosed by diabetes, the whole world changes. When he goes into the society, he has to take care of his foods. Thus, diabetes demands a high level of self-efficiency, resilience, then perceived control and empowerment. Now, all these things need a strong mind so that people can have good control on diabetes. So let me tell you, international and national guidelines have also started acknowledging emotional and mental health of people living with diabetes because it has impacted a lot overall long-term prognosis, control, and quality of life people with living with diabetes. And that's why guidelines have come up with a recommendation. And the first that I'm going to talk here is Diabetes UK guideline, which says that commissioners and service providers should work together to ensure emotional and psychological support for people with diabetes of all ages, and it should be embedded in each step of diabetes care pathway and is not limited to patient who is diagnosed with psychological problem. So most often when a patient is diagnosed with psychological problem, he is attended with a psychiatrist. However, the guideline says that even if there is no diagnosis, you need to give emotional and psychological support to patients or people living with diabetes. American Association of Clinical Endocrinology says that screening for depression should be performed routinely for adults with diabetes because untreated depression can have serious clinical implications for patients with diabetes. Patients with depression should be referred to mental health professionals who are members of the diabetes care team. So this is increasingly being recognized and has to be taken care. There are some separate guidelines for type 1 diabetes. We know type 1 diabetes needs lifetime insulin. So there is a higher incidence of subclinical depression and anxiety in these patients. National Institute of Health and Care Excellence NICE guideline 2015 has said about this. A Scottish guideline says that regular assessment for a broad range of psychological and behavioral problem is recommended. Now comes certain guidelines about type 2 diabetes, and what we are going to talk today is about Royal Australian College of General Physician guideline and IDF, that is International Diabetes Federation guideline. They say that annually patient with diabetes can be assessed for mental health issues, social isolation. Similarly, IDF says explore the social situation, attitudes, belief, and worries related to diabetes and self-care issues. So all these psychological part is increasingly being recognized, increasingly being included in different guidelines across the world. Now, let us go towards the side of the patient. Let us experience it. If a person comes with type 1 diabetes, just imagine in which psychological condition he is and what are his expectations from a diabetes physician. So patient feels that diabetes consultation often feels like one-way street. I mean, doctor is speaking, patient is listening, doctor is commanding, patient has to follow these things. It's the professional telling what you need to do, and there is a lot of exploration how difficult that may be for you, how worried you may be about it. So this is what a patient thinks. You know, somebody is going to tell me professionally, these are the things that you need to do, and they really don't know, or they really are not exploring it, how difficult it may be for the person who is having diabetes to follow them. They don't necessarily explore with you how you are managing within yourself. So difficulties that a person with diabetes is facing, I mean, healthcare professionals really don't know. That is what a patient feels. Being about to talk about these things make you feel that your health professional is actually interested in you as a person and in your situation. It is very empowering and validating. It makes you feel that it's okay for you to have these concerns, anxieties, fears, and feeling that it's actually normal and okay. So if a health professional allows you to talk, a person say, if I have diabetes, I wish to talk about my anxieties, fear, and feeling, and the physician should hear it and he should feel the part, then only it becomes appropriate consultation, and then only diabetes physician is taking care. So when you have to take care of the psychological need, the first thing that starts in the consultation is communication and engagement. Let me tell you, People with diabetes want supportive health professional with whom they can discuss any aspect of living and managing the condition. So, an open, emphatic communication style is important in enabling people with diabetes to talk about their emotional and mental health. The language that health professionals use can affect patients' willingness to talk about the challenges of living in the diabetes, their motivation, self-confidence, self-management skill, and diabetes outcome. So, as with any skill, communication skill can be acquired and improved with practice, and its confidence increases with time. So a health care professional should start practicing improvement in the communication skill so that their patient express and what they have to do in their clinical practice so that their communication with the patient improve. A doctor should seek to meet the person where they are in their life rather than where you would like them to be. So, you want these things to be done, these things to be done, these things to be done. You start saying these things to the patient. First of all, you should understand what he is, where he is. Then only you can have effective communication. Then only you can bring about the expected changes. The second part of the communication is active listening. Most of the time, health professionals speak more. The best way to improve the communication is active listening. Open and emphatic communication, that is verbal and non-verbal, improves the quality of consultation and is essential for best clinical practice. Reflect on the proportion of consultation time that you spend on talking rather than listening. Is it balanced? Consultation are typically more effective when person with diabetes talks more than the health professional. And most of the time in clinics, we don't give adequate time to listening. We start talking and which that patient has to say. So there is some ABC, DEF sort of things, how to improve the effective communication. The first part is active listening. Active listening is fundamental communication technique that improves a range of verbal and non-verbal skills. Then comes body language. Look for the signs that someone is not doing okay despite what they might be saying verbally. Observe person's non-verbal communications, facial expression, body language, any inconsistencies between their verbal and non-verbal communication. Effective communication has to be brought about. Clarify information and paraphrases. At times you need to repeat the words that patient has said so that they can clarify. So reflecting or paraphrasing are important. They may say something you might have understood it in some way. So you need to paraphrase it and ask him again if they really mean what you have understood, so that communication or the information that patient gives to you becomes more clear to you. Similarly, when you ask them to say what they have understood. That is what improves the communication. Then you need to develop rapport. Most people with diabetes want someone on their side, someone who can help and support their self-management efforts rather than someone who tells them what to do or criticizes them. So just try to develop a rapport, try to develop their a relationship, understand their problem so that they may get more motivated. The another part of the effective communication is explain clearly. So don't use jargons which are difficult to understand. Simple sentences, simple things, you talk them. I mean, talking about a very complex diet plan and explaining many big things which patient may not understand. Tell them in simple words what he has to do, what is good for them. So that is what we need to do. Sure to take feedback, because how they feel, does the doctor need to answer something which he has not been able to do? So these are important. Give clear signals, set up expectation at the start of consultation. Let the person know you need to move on to another issues draw consultation to close. So these are effective way. Hear the sound of silence. At times, patient may take a pause. Okay, he might be recapitulating something. Give adequate time and then initiate the discussion again. And in conclusion, summarize the main issues at the end of consultation, including any agreed action plan to make sure there is mutual understanding of what has taken place and how to move forward. Offer an early follow-up appointment that you just to show that you are interested to continue the conversation to find out what happens when they try out agreed action plan. So these are effective communication methodology which you can use in our clinic, so that once a communication is established, half of the psychological distress goes away. Let me tell you, when a person is diagnosed with type 2 diabetes, most of the psychological or distress, psychological problem or distress starts with the consultation. And if you are able to have an effective communication, let me tell you, at least 50% of the psychological concern or distress associated with diabetes is already resolved. So this is what we need as first thing when we talk about psychological needs of a patient of type 2 diabetes. That is improvement in the communication with the patient. Make the communication more effective. Now, let me tell you, facing life with diabetes or experiencing the diagnosis of diabetes comes up with a lot of reactions, a lot of modifications within the patient. Living with diabetes involves acquiring new knowledge. Patient didn't know what is normal sugar values, what are the, hypoglycemia, what is hyperglycemia, what are the complications, how they are going to manage it. This self-management has to be taken throughout the life. So they really don't know, and that is a new knowledge that has come to them. And thus, response to diagnosis can vary. Some people experience a range of negative emotions कि now they have got diabetes, अब तो जीवन खत्म. अब उसको डायबिटीज हुआ था, उनका किडनी फेल हुआ, वो मर गया, उसको हार्ट अटैक हो गया, वो मर गया. So they may have negative emotions like shock, grief, anger, distress or self blame. वो मेरे कारण डायबिटीज हो गया. While others diagnosis may have little impact. बहुत सारे लोग कैजुअल होते हैं. They think कि ऐसा डायबिटीज होता रहता है सबको, अरे क्या फर्क पड़ता है, आजकल तो सबको डायबिटीज हो सकता है. So there can be a wide range of psychological response. You need to find out what actually patient is having, and then you need to communicate the things in an emphatic way. Responses are influenced by type of diabetes diagnosed by the person, individual characteristics and experience prior to the diagnosis. The journey is different for everyone, but most people with diabetes will need support from their health professional, families, and peer at some time. So the diagnosis of diabetes come with its own reactions, and we need to include them in our practice. So the practice points are: reflect on how you might feel if you had to live with diabetes. Use your insight to support the person. Be mindful that a new diagnosis can raise a range of emotion for a person. Let me tell you my personal experience. Once a 65 or 70-year-old hypertensive patient came to me with a diagnosis of diabetes, and all their family members were too apprehensive. They were rather denying the diagnosis of diabetes. They were not ready to accept, because they felt that if I talk about diabetes to the patient, he would get depressed and all those things. So response may be different. We need to find out, and we need to communicate appropriately. We need to listen emphatically, assist the person, assure them that you can support them to live well with diabetes. Now, certain reactions with diabetes. Type 1 diabetes, I have already told you. Type 1 diabetes may be a big news, not only to the person, but to the whole family. It may be traumatic. It may be considered devastating by the person. So these are typical reactions which may include shock. So we need to understand that the person is really needing psychological support. Similarly, diagnosis of type 2 diabetes, reaction to type 2 diabetes may range from, apathy, denial to, self-blame. We need to understand what is their psychological need. Depending upon that, we need to appropriately respond. Now, let me tell you that when a diagnosis of diabetes comes in, it starts a lifelong relationship with health professional. The diagnosis is going to stay, the disease is going to stay with the person throughout the life. Thus, we should try to help a person to make the changes which fits diabetes into their life. So when asking people to make significant changes in their lifestyle, it is important to convey a message of empathy, understanding while being factual and informative. It is important to refrain from using threats or fear-based persuasion, particularly if person is not ready to face the reality and the consequences of diabetes for their future. That is the example I told you, the old 65-year-old person who came to me. They were not ready to accept the diagnosis because of the threat or perceived threat or fear based on persuasion. It is more constructive to understand why a person may not be making the change that would appear good for them. Successful completion of one step increases people's confidence in taking next step in their lifestyle modification. So you have to gradually build in the goals. One by one, you need to tell them how changes they have to do in their life, which would fit in their life as a diabetes. So with all these in mind, explore what options they have for making changes that would benefit their health. Work with the person to develop a realistic, individualized action plan and to identify resources to aid change. Ensure that actions you agree upon are relatively easy with few barriers. Now, with the initial requirement, the communication, let us move to a particular entity which is called diabetes distress. It is very common. It is seen in up to 40 to 50% of the people living with diabetes. So diabetes, the feeling that a person may have is that diabetes can be really tough to live with. Sometimes people feel distressed, which can include feeling frustrated, guilty, sad, or worried. It is understandable if you feel that this way from time to time. You are not alone. There are many things you can do to reduce your diabetes distress. So what a typical, feeling that a person, I would say 62-year-old person has got when diabetes. Now she thinks that I think the hardest thing was as soon as you start checking your sugars and you don't watch them go down. So, I have started taking medicine and my blood sugar is not going down. I have started doing all lifestyle modifications. I'm not eating. Patient will come to you and say, Doctor, I don't eat anything. I keep on, taking all my medicines, but my blood sugar is not going down. That is a big distress. It's not something that you deal with every 3 months when you get your blood test done. This is what the patient sees almost daily or every week, those who are doing self-management and blood sugar. So that keeps on, putting a negative stress upon them that, yes, my sugar is not decreasing. My sugar is not decreasing. And that is what distress is. So what is diabetes distress? Diabetes distress, also known as diabetes specific distress or diabetes related distress, is the emotional response to living with diabetes, the burden of relentless daily self-management. Self-management is not limited to just blood sugar monitoring. Self-management needs dietary restrictions, exercise. I mean, it has got a lot of component, and thus any person who has got diabetes is doing self-management. That self-management may not be an extensive self-management, but self-management is there, and that self-management, relentless daily self-management, has got its effect on psychology, and that is what we call diabetes specific distress. Then prospects of its long-term complications, the limitations that self-management brings in the freedom, that is what diabetes distress is. It can also arise from social impact of diabetes, like stigma, discrimination, dealing with other people's unhelpful reaction or their lack of understanding, financial implications, insurance treatment cost for the conditions. Actually, diabetes distress is very, very common. 1 out of 4 people living with type 1 diabetes and 1 out of 5 people living with type 2 diabetes have diabetes distress. Let me tell you, diabetes distress is an emotional distress resulting from living with diabetes and the burden of relentless daily self-management. Severe diabetes distress affect 1 in 4 people with type 1 diabetes and 1 in 5 in type 2 diabetes. Greater diabetes distress is associated with suboptimal diabetes self-management, HbA1c, and impaired general emotional well-being. Diabetes distress is sometimes mistaken for and is more common than depression. Problem areas in diabetes is a scale which tries to identify if patient has got diabetes distress. Diabetes distress is best managed within the context of diabetes care. Although greater diabetes distress tend to be associated with higher HbA1c, optimal HbA1c not necessarily indicate that patient doesn't have diabetes distress. So how to tackle diabetes distress in patients in our clinic? Let me tell you that diabetes distress is relatively common and also impacts upon self-care. It is important that in every consultation, we include opportunity for person to express how they feel about their life with diabetes. Let them speak what are the limitations that they do have. Remain mindful that certain treatment options may increase the burden of diabetes self-care management and increase the likelihood of diabetes distress. Collaboratively set an agenda for consultation, talk about what each of your priorities are for today, and agree how much time to decide on each topic. How can we identify diabetes distress? Be aware, know that diabetes distress can be there. So if a person comes to you with suboptimal HbA1c or unstable blood sugar, he is not attending clinic appointment, there is reduced engagement with diabetes self-care tasks, ineffective coping strategies with dealing, multiple negative life stressors, impaired relationship with health professional, appearing passive or aggressive during consultation. Just look at your consultation, which you have done today itself. You will see that if you see these 7 points, almost half of the patient who came to your chamber today with diabetes had one or the other such situation. Now you have identified that probably these are the people who do have diabetes distress, and we need to once again talk to them and improve our communication skill so that we can identify the problem. There is a simple 7A model which tackles with diabetes distress. The first was aware, that I told. Be aware that people with diabetes may experience emotional and mental health problem. So you need to ask about emotional and mental health problem. You need to assess for mental health and medical problem. If you feel that this is severe, which requires a referral, you need to assign a psychologist for them. Then you need to advise about emotional and mental health problem. And if still you feel that your advice is inadequate, you need to refer them to the psychologist. You need to assist them in developing achievable action plan, and then you need to arrange follow-up either with yourself or with the psychologist so that their distress is taken care. So how can you help? Be aware, ask and assist. And how can you support? Advise, assist, assign, and arrange. Now we move to the another psychological stressor in diabetes, and that is fear of hypoglycemia. This fear of hypoglycemia is also a very important psychological issue. Fear of hypoglycemia is a specific and extreme fear evoked by the risk or occurrence of low blood glucose level. Fear of hypoglycemia affects 1 in 7 person with type 1 diabetes or type 2 diabetes. These fear also affect family members. So, many times patients tend to undertreat themselves. Hypoglycemia fear survey is there to find out if patient has got hypoglycemia. Psychoeducational intervention are effective in reducing the fear for hypoglycemia. People with diabetes and their families often have limited knowledge of hypoglycemia without beyond survival skill, which may lead to fear of hypoglycemia. So these are the causes of fear of hypoglycemia, and we need to understand it and include something in our practice. These include acknowledge that fear is a normal response or threat to hypoglycemia, and that a certain level of fear is adaptive. We need to tell them that yes, diabetes hypoglycemia is a possibility. We need to know that. So adaptive fear has to be there, which keeps the person alert for the symptom and keeps the person motivated for self-management of this hypoglycemia. But acknowledge that extreme fear may impair person's well-being. Don't tell them that you need to be watchful, but don't be fearful. That is what you need to tell them. Be aware that a person may experience extreme fear of hypoglycemia in absence of actual hypoglycemia, irrespective of their HbA1c. I mean, there are patients who have got bad memories of hypoglycemia, which they might have seen in their neighborhood or in their family, and that is irrespective of whatever blood sugar or whatever HbA1c they may have. So remain mindful that people may be reluctant to talk about their fear of hypoglycemia with health professional. You need to talk to them and you need to find out how this fear can be addressed. Now, the fourth psychological problem that a person living with diabetes is psychological barrier to insulin use. We all know that fear of injection or syringe is always there. So psychological barrier to insulin use are negative thoughts or feeling that people with diabetes may have about starting using or intensifying insulin. At times they feel that when insulin has started, their end of the life has begun, and they may not be willing to start insulin despite knowing that insulin is going to benefit them. People already using insulin are sometimes reluctant to optimize or intensify insulin. Psychological barrier can be associated with delay, reduction, or discontinuation of insulin use, which can lead to suboptimal blood glucose level, increased risk of diabetes complications. So there are a brief questionnaire, insulin treatment appraisal scale is used for identifying psychological barrier to insulin use. There is little empirical evidence about the best way to minimize the psychological barrier to insulin. Recommendations based on clinical experience emphasize anticipating, acknowledging knowledge barriers. So how to tackle this insulin barrier in your clinical practice? Help people to understand the natural course and progressive nature of the type 2 diabetes and the likelihood that their treatment will change over the time. Right from the beginning of diagnosis, you need to tell them. Emphasis that needing insulin doesn't mean that they have failed. It is actually part and parcel of the disease. Be aware that people using diabetes, as well those not yet on insulin, experience a psychological barrier to insulin. Every person will have different concerns. Ask them what their concerns are rather than making assumptions. Monitor for signs of psychological barrier to insulin, particularly when a person's HbA1c is above target for some time. There is no sign that they are ready to transition to insulin or intensify insulin. Now we come to another aspect, that is depression and then anxiety. Depression is common. Patient with type 1 diabetes, 1 in 5. Patient with type 2 diabetes who are on insulin, 1 in 3, and patient with type 2 diabetes who are not on insulin, 1 in 4. So what is depression? Depression refers to a wide range of mental health problems characterized by absence of positive effect, that is a loss of interest and enjoyment in ordinary things and experiences. It includes low mood and a range of associated emotional, cognitive, physical, and behavioral symptoms. Depression in people with diabetes, there is evidence that bidirectional association exists between depression and diabetes. People with depression are more likely to develop type 2 diabetes, and people with diabetes are more likely to develop depression. The most important points of depression in diabetes includes following. Major depression is a psychological condition indicated by a persistent state of lowered mood or lack of interest or pleasure in usual activity. Moderate to severe depressive symptoms, an indicator for depression, affects one of the 3 people with insulin-treated type 2 diabetes, 1 in 4 with non-insulin treated type 2 diabetes, 1 in 5 with type 1 diabetes. Depressive symptoms in people with diabetes are associated with suboptimal diabetes self-management and HbA1c increased diabetes distress, less satisfaction with treatment. Depression is usually recurrent and different from yet confused, and it's a little bit different from diabetes distress. Some depressive symptoms overlap with symptoms of diabetes, and we need to use questionnaires to find out if patient is having diabetes. How we need to tackle depression in people living with diabetes in our clinics. Assess people with diabetes for depressive symptoms using a brief validated questionnaire. Remember that major depression needs to be confirmed by a clinical interview. Treatment of depression will depend on severity, context, and the preference of individual. Helping people with major depression to assess suitable treatment may require a collaborative care approach beginning with person's GP. Remain mindful that depressive symptoms and mild depression also need attention as they can develop into major depression. And then the last thing that we are going to talk today is the anxiety disorder, the psychological aspect which a people living with diabetes may have. An anxiety disorder is a psychological condition characterized by persistent or excessive anxiety or worry that is known as clinical anxiety. The worry is accompanied by a variety of symptoms which may include emotional, getting panicked, weeping, cognitive, thinking of one cannot be stopped, behavioral, they may get aggressive, restless, or maybe physical, rapid heartbeat, sweating, nausea. All these things may happen in anxiety. Once again, anxiety is also very common. And elevated anxiety symptoms in people with diabetes are associated with suboptimal diabetes self-management, metabolic outcomes, and diabetes complication. Depressive symptoms and impaired quality of life is there in people with anxiety. Can be difficult to recognize as severe anxiety, and panic attacks share some similar physical symptoms of hypoglycaemia. So you need to be very much watchful, and you may use some questionnaires like generalized anxiety disorder 7 GAD7 scores to find out the anxiety in people living with diabetes. How we can tackle the anxiety disorder in our clinical practice. Assess people with diabetes for elevated anxiety symptom using a brief validated questionnaire. Remember that anxiety disorder need to be confirmed by clinical interview. Treatment for anxiety disorder will depend on severity, context, and preference of the individual. Helping people with anxiety disorder to assess suitable treatment may require a collaborative care approach beginning with person's GP. Remain mindful that elevated anxiety symptoms also need attention as they can develop into anxiety disorders. So with all this background, we also need to understand when I need to take help from our mental health professionals. So in general, people with diabetes tend to prefer their diabetes health professional to support them for their emotional aspects of diabetes. So diabetes distress, psychological barriers to insulin, fear for hypoglycemia, depression, anxiety, disorders, in all these conditions, patients or people living with diabetes want their diabetes physician to tackle them. They don't want to go to any other doctor. So if a person is experiencing mental health problem, we need to, then we need to take care of that. And if we don't have expertise, then we need to refer it to mental health professional. Some mental health problems require immediate attention and referral to a specialized service like eating disorder or acute depression, acute suicide risk. In all these conditions, we need to take help from our mental health professional. Talk with the person with diabetes about the reasons for referral. Ask them about their thought and feeling about this. So you need to talk, because they are reluctant. They don't want to go. You need to talk to them. Continue to see the person with diabetes after referral to health assured. So let psychological part be dealt with the psychologist. You keep the patient in your follow-up. Keep talking to them about those symptoms also, so that they remain involved, they remain positive. Maintain ongoing communication with health professional to whom you have made referral to ensure a coordinated approach to person's ongoing care. At the end, I would like to summarize my talk about how to tackle with psychological problem, and this pyramid is what explains it in a very good way. Level 1 psychological problem are general difficulties. I mean, people living with diabetes will have some or the other psychological problem right from the diagnosis till their end of the life, and we need to understand what level of psychological problem they have and then take appropriate action. So level 1 are general difficulties coping with diabetes and the perceived consequences of this for their person's lifestyle. Problems are at a level common to many and most of the people living with diagnosis, and here effective communication and helping them at your clinic may be sufficient. Level 2 is more severe difficulties with coping, causing significant anxiety or lowered mood, impaired ability to care for self as a result. Here, an extensive diabetes consultation, having a psychologist at your place, a good diabetes educator to let them how to live with diabetes would help. Level 3, psychological problems which are diagnosable, classifiable, and can be treated solely through psychological intervention. This is once again you can do at your own level. Level 4 is more severe psychological problems that are diagnosable and require biological treatment, medications, and specialist psychological intervention. These are the places where we need to take help from our mental health care professionals. Then level 5 is severe and complex mental health illness requiring a specialist psychiatrist intervention. These are the places where you should immediately consult the psychiatrist for appropriate management of the psychological problem. So this is how we should take care of the psychological needs of people living with diabetes. Thank you very much for your patient hearing. Back to MedTech people for questions, if any.
There are some questions now. So I will be posting the questions one by one in the chat, sir.
Perfect.
Yeah. So I posted the first question.
Okay, so what is the relationship of psychological stress factor to clinical presentation of diabetes? See, I have told you a couple of things today itself. A diagnosis of diabetes itself comes with a lot of psychological stress. A person who has been diagnosed with diabetes may rather come to you in a very depressed mood, in a state of anxiety. So the way diagnosis is perceived, diabetes diagnosis is perceived, they would present you like that. A person may come to your clinic with a diagnosis of diabetes with a lot of apprehension, with a lot of psychological distress. Now he has lost his freedom. Now he has to test his blood sugar. Now he has got risk of hypoglycemia. He will get all these diseases. He will ultimately die. So this is one spectrum of psychological distress which will come. Now these psychological factor will present to your clinic not as a psychological disease. They will come to you as a patient of diabetes and they may complain of all these problems. So this is how psychological stress factor affects the presentation of diabetes. A person with diabetes may not come, my sugar is this much, my sugar is that much. Doctor, I am not able to sleep, I am not able to eat properly, I feel I will die, and all those things may come if a patient is psychologically distressed. So we need to identify the problem area in the patient. Is it associated, is it all anxiety associated with diabetes? Once you do an effective communication, you tell them about all these things are because diabetes. You tell them about that if you tackle diabetes properly, all these complications would end or all their fears will go away. That is the way we need to understand the problem. We need to communicate effectively and thus tackle it in our clinics. Thank you. How depression and anxiety affects diabetes? I told you that incidence of diabetes and depression is, correlated with each other. Incidence of depression is increased in people living with diabetes in comparison to those who do not have. And similarly, incidence of diabetes is increased in people who have depression in comparison to those who do not have depression. Depression is quite common in diabetes. Similarly, anxiety is also common in diabetes. Anxiety is an excessive worry, excessive response to any problem. And these are seen to be commoner in diabetes, people living with diabetes, than those who do not have diabetes. Thank you. What psychological therapies are helpful in treatment of diabetes? Let me tell you, I just told about these things. Psychological therapy, first is that people living with diabetes want their diabetes physician to tackle with it. And the best way to tackle psychological problem in people living with diabetes is effective communication. Most of the time, because of lack of knowledge, people have got a lot of fear, a lot of anxiety, a lot of distress. So once you talk to them, there is effective communication. You do a good diabetes education. Tell them what is the best way to live with diabetes, how to do adjustment in small things in their life so that they can live happily with the diabetes. Let me tell you that psychological distress usually comes because of the fear associated with this disease. Fear associated with diagnosis of disease, fear associated with treatment of the disease, fear associated with complication of the disease. So an effective communication, effective diabetes education is the first thing that you need to do as a part of psychological therapy for people living with type 2 or type 1 diabetes. Thank you.
Hello.
Go ahead.
Yes, sir, we are done with all the questions. Yeah, and thank you very much, sir, for your time and sharing some valuable insights on the topic, sir.
Perfect. It was my pleasure. Thank you.
Yes, sir. Thank you very much.